Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. In this episode, I want to talk to you about what I believe is the most important part of performing a total knee revision, and that's restoring the joint line. The joint line is important to restore even in a primary setting, and a lot of studies have shown that it's even more important in a cruciate retaining knee, and you have a little bit more wiggle room in a posterior stabilized knee. But what I've seen and what I've learned and what I've read, and I'm going to explain to you kind of my experience with it, is that the restoration of the joint line is extremely important. And I believe for a long period of time, we didn't really pay the greatest attention to restoring the joint line, or maybe didn't have the information or the tools to restore it well. So, if you go back to, and I always hate to use that phrase, when I was in training, but when I was in training, and again, I try to leave out real specific with particular implant companies and things now, but back then, the really, really common revision systems that we used were the J&J TC3 and Zimmer's CCK. And where I trained and how I was taught and what we did a lot of times was you were taking out the tibia and the femur, and you were basically freshening up the bone on the tibia and the femur to give you flat surfaces. And then from there, we basically used the implants as tinker toys to basically build the implant and trial. And essentially, it was like using a full range of motion flexion extension gap checker, because you put it on and up, too loose, too tight, upsize, downsize, add an augment, remove an augment. And it worked, but I don't believe now in hindsight that it worked really well. And, we all know from, past experience and the data, the old mantras were, try to look for your meniscal remnant if you're doing a revision. And realistically, that's hard, especially if the person that did the primary took it all out, or 2 finger breadths above the tubercle or 2 centimeters above the fibular head. And, if you've been in a knee, a lot of times, unless they've lost a lot of tibia, it's really hard to see or feel the fibular head. And, the tubercle variability is huge. And someone has Osgood Schlatters, they got a large tubercle, and maybe the tubercle's really shifted laterally. They have some bone loss. You can use the patella and its particular position with flexion and extension. So you can use all of those things. And those were some of the more old, ways and techniques of trying to restore the joint line as best as we can. But even when we did that, I believe that most people, including me, elevated the joint line. And when you do that, it increases the joint reactive forces. It causes this patella baja. It decreases your range of motion. I always remember that a centimeter of joint line elevation decreases your flexion by 25%. But every time that we did this, it changes the mechanism of the knee and the way that the mechanics of the collaterals function. And it was always sort of this big disaster. And I remember this epiphany as we started to get more aware of the joint line. And someone, and I forget exactly who told me, they said, listen, anybody not using an augment or even a small augment on a revision is probably elevating the joint line. And it really made me think about all the times that we, didn't put a big augment or sometimes no augment on the femoral component. And nowadays, more commonly, I'm using, 10, 15 millimeter augments on a regular basis. And that's really helped. So the thing that I think has helped me the most is when one particular company came out and their distal femoral cutting guide. Actually, the designers looked into the research and the data, and they extrapolated all this information, and the number that they came up with was 28 millimeters from the medial epicondyle. So, what happens on this distal femoral cutting guide is you have a little slot where you can drop your angel wing, and you can feel the sulcus of the medial epicondyle, and you can drop the angel wing in there, and this way you can pin your distal cutting guide and it has essentially restored your joint line. So now you can drop your saw in and go, okay, 0, airball, medial, lateral. Okay, 5 millimeters, still airball. Okay, 10, I can take a little bit of bone medially, but I'm still an airball laterally. Saw blade 15, boom. There you go. I tell my tech 10 on the medial, 15 on the lateral, and he can start building that on both the 4-in-1 cutting guide and the gap checker if I'm going to use that, and my trial. So now I'm set up for that, as opposed to just making a flat cut and then sizing my femur and then kind of tinkering around with adding augments. Now, there's another system out there, and they have a similar plan, but it's later on in the process. So I really like this philosophy. So even if I'm using a different system, I'm still getting my ruler and going, okay, 28 millimeters, medial epicondyle, this is where I expect my joint line to be, and then using their distal cutting guides to figure out where my freshening cuts need to be. Because if you know where the joint line is from the get-go, that you've at least determined, okay, this is my extension gap. This is where the distal femur needs to be, because the next hardest part is posterior condylar offset. But this is an important thing. Now, we're always learning. Our job and our career as an orthopedic surgeon is to be in continual motion and learning and educating ourselves and others. So I actually learned something new in just researching the information on this topic. And some of you may already know this, but the idea of this adductor ratio. So what a lot of studies more recently have looked at is the idea of this 0.52 ratio. So if you look at the width of the distal femur and you multiply that by 0.52, or if you're in a pinch, just in half, what they've determined is the distance from the adductor tubercle, which they found for a lot of people was a little bit easier to feel and identify than the medial epicondyle, that 0.52 times the femoral width gives you where the joint line should be. And this was accurate, I believe, to within 4 millimeters in greater than 90% of the cases. So this is this other option that you can utilize in addition to that tool that I use, which is the 28 millimeters, that allows me to restore the joint line. Because, the next step for me is then balancing your gaps. That's obviously one of the goals of total joint replacement, is to balance our gaps and make sure that we have a good functioning knee. But what we then find is that if you know what your extension gap is, and let's say we have our arbitrary 10 medial, 15 lateral, a lot of times you can take the old femoral implant and line it up size-wise against the system that you're using for the revision and get an idea of what size it is. You can lay it on there, but more often than not, the flexion gap's quite large. So at this point, you have to make this decision of, do I need to upsize my femur to close down my flexion gap? Do I need to offset my femoral component with an offset stem to just take the same size medial lateral, because otherwise you'd be overhanging, and drop it posterior? And then at least this way, nowadays, I feel that I'm starting out in a much narrower window. Maybe making a little alteration of one size augment and making these minor adjustments to figure out, okay, what do I need to do to balance this knee as good as I possibly can? Whereas before, it was just give me a 5, give me a 10, give me a 15, take off the 15, put a 10 back on, add this. And you were really, really starting from scratch. And that was sort of the old way, the old philosophy of doing it. So taking away from this, and obviously the revision total knee is a whole nother series of umpteen episodes. But this is, I think, in my opinion, the most important part of that operation. So I just wanted to lay those points home that, when you're in there, is that you need to restore your joint line. And the most effective way that I found in my hands is off of that sulcus of the medial epicondyle, 28 millimeters to the joint line. You obviously, and again, should check it with 2 or 3 other options. So nowadays I'm going to start checking it with that 0.52 ratio times the width of the femur and seeing that distance from the adductor tubercle. Obviously, if you see a meniscal remnant, you can use that, and you can use other landmarks as well, looking at the patella, looking at the tubercle. But at least this way, you've then identified the joint line from the distal femur, and now the next step is then going to be balancing your flexion gap to that extension gap, using the tools in your hands such as upsizing the femur if you're loose, downsizing if it's tight, or potentially using an offset stem if you need to adjust the femoral component, maintaining the same width so you don't develop overhang. So my 2 cents on joint line. Obviously, it's this could be a whole week-long symposium just talking about joint line if we wanted to delve into it, but this drives home those points. If you found this information useful, please share it with your friends and colleagues. If you do have the time, I would really appreciate it if you could leave a review on iTunes so that other people that are looking for this type of information may find it. And until next time, you've been listening to the Total Knee Tips and Pearls podcast. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.